Dr. Bar. I'm a PGY2 internal medicine resident at Adulthood, Orlando, and today I'll be presenting a case of 16 years of indolent progression in a multifocal sporadic pancreatic neuroendocrine tumor diagnosed in young adulthood. For background, pancreatic neuroendocrine tumors are uncommon malignancies that typically present in later adulthood. Multifocal pancreatic involvement is most often associated with hereditary syndromes, whereas sporadic tumors are usually solitary. Although low-grade pancreatic neuroendocrine tumors are known to exhibit indolent behavior, long-term documentation of untreated disease progression beginning in childhood and adolescence is rare. This case is notable for its exceptionally young age at diagnosis, extensive multifocal sporadic pancreatic involvement, and prolonged indolent course spanning over 16 years. For our case, we have a 28-year-old woman with history of congenital hypertrophic cardiomyopathy and prior cardioverter defibrillator placement, came in with abdominal pain. CT scan revealed a bulky lobulated enhancing mass encasing the pancreas with extension into the gastrohepatic space and had hypodense foci and calcification. There was regional lymphadenopathy but no evidence of mets in the liver or peritoneal involvement. Her retrospective review of imaging reveals similar abnormalities in the scans that were obtained in 2020 and dated as far as back to 2009, when the patient was approximately 12 years old, indicating more than 16 years of subclinical disease evolution. She underwent endoscopic ultrasound with fine needle aspiration and was found to have a large mass involving the pancreatic body and tail, measuring at least 7 cm at that time, with extension into the peripancreatic space. Her cytological analysis did confirm a low-grade pancreatic neuroendocrine tumor. Given the concern for resectability, initially the patient underwent exploratory laparotomy and a distal pancreatectomy and splenectomy was planned. However, intraoperatively, extensive multifocal tumor involvement and in the entire pancreatic parenchyma, including the head, uncinate process, neck, body, and tail, with encasement of the celiac artery and large celiac portal and periaortic lymph nodes. Due to the diffuse involvement and vascular involvement and requirement for near total pancreatectomy and low likelihood of meaningful cytoreduction, surgical resection was aborted at that time. Pathological evaluation of the sampled lymph nodes did confirm a metastatic neuroendocrine tumor. Germline genetic testing revealed no pathological findings, therefore supporting sporadic rather than hereditary etiology. For discussion, there are several important teaching points with this case. Firstly, pancreatic neuroendocrine tumors can present at an unusual young age and can have a very indolent progression over many years. Secondly, extensive multifocal pancreatic involvement can occur in sporadic germline negative cases, challenging the traditional association of multifocal disease with hereditary syndrome. Thirdly, indolent tumor biology does not preclude locally advanced disease or surgical irresectability. Finally, this case does underscore the importance of longitudinal imaging review and individualized multidisciplinary decision making when managing neuroendocrine neoplasms. Management options that were offered in the multidisciplinary setting included systemic therapy with capecitabine and temozolomide, also with somatostatin analogs such as lanreotide and peptide receptor and radionucleotide therapy, and close monitoring and surveillance. Thank you.